Hello, everyone. Welcome to the Taking Control of Your Diabetes podcast. And I'm one of the two co-hosts, Dr. Steve Edelman, and unfortunately, my good friend and colleague and co-host, Dr. Jeremy Pettis, can't be with us today. We both have type 1 diabetes. We work at UCSD, and we also work for the not-for-profit Taking Control of Your Diabetes. Want to remind everybody to please like and subscribe to the podcast. And remember that we're videotaping all our podcasts. So there's going to be on YouTube as well as the podcast stations. And look out for a lot of great videos we have set up for 2025. So today we're going to talk about the TEDdy and Cascade studies. These are two 20-year-long studies looking at environmental and genetic factors that lead to the development of type 1 diabetes, and I could say in at-risk individuals, and we'll learn a lot about it. Today we have Michael Killian. He's the director of the clinical services at Pacific Northwest Research Institute, and he is one of two researchers that have been doing this very long-running international studies that have given us so much information on what are the risk factors leading to type 1. And I would say, you might agree, had brought up probably more questions than answers because this is a tough area to tackle, which is the cause of type 1 diabetes. Introduce yourself, Michael. And my first part, as you introduce yourself, what led you to spend 20 years of your professional career in this area?
Okay, great. Thank you so much. And thank you for having me here. I will say I got a chance to listen to some of your podcasts, and I always find it a little more fascinating when you have an endocrinologist who has, that real personal experience with type 1. So let's see, myself. I've been with my husband for about 31 years now. We have 2 grown kids. I've been living in Seattle for about 30 years. Before that, I worked as a paramedic in Alabama and down in Los Angeles. Not a big fan of California, but
you know what? A paramedic turns type 1 researcher. I love it. Well, tell us a word about your co-host, because I know you guys are a close group of guys that working very hard to advance the field of type 1 diabetes.
Well, so I'll say, the thing that got me into this is I decided to go back to school and look at other things. And as a student, started doing research and just found the idea of it and kind of the way it worked and the puzzle of it very, very interesting. And so very exciting that, I've gotten to spend this much time doing this. I should correct you a little bit. You said, one of a couple. On TEDdy, there are so many of us on this project. I mean, it's a huge project with 6 clinical centers around the world, and it's been an immense project and joy to kind of undertake as we try and understand, what are those environmental factors that kind of trigger the disease. I'll step back a little bit. Kind of, before TEDdy started, we had some precursor studies that looked at, trying to understand the disease process. And with TEDdy, we were pretty clear, okay, genetics, you have to be predisposed to get type 1, but then there's this black box, something happens. And that was really what we were charged with. And I have to say, the NIDDK was very clear from day one all the way through today. It's your first goal is to understand what are the environmental factors that trigger type 1 diabetes. And you're absolutely right. It has led to probably more questions than answers, but now we're asking better questions. And it's the more we understand, the closer we can get to really grasping this and understanding how to prevent this disease.
Yes, and when I listened to your podcast that you did in the past, I mean, you said something very important. This kind of research doesn't occur overnight. It takes time, and your advances within your study probably change direction as you learn more and more. Well, let's tell our listeners and viewers now, what is the TEDdy study? And it stands for the Environmental Determinants of Diabetes study. So it's such an important study because, as you mentioned previously in your work and your publications, you get the genetic risk. Not everyone goes on to type 1 diabetes. So what can explain those that go on and what those that do not?
So kind of what we believed, our hypothesis that we wanted to test here was that, you start with genetic predisposition, and then something in the environment comes along and triggers the immune system to start the attack. The vast majority of people, I mean, there's about 5% of the people walking around who are genetically predisposed to get type 1, and the vast majority will never get type 1 at all. And so there's something in that smaller set that starts the process going. And there's a lot of different things that we looked at and we were interested in. But viruses and diet and psychosocial factors all really kind of continue to kind of bubble up to the top there. And so, our goal was really just to look at, to follow these kids, which is, an observational study they were from birth to 15 years. The whole study is a little over 20 years, but the kids are birth to 15 years. So it's a lot trying to figure out and tease out kind of what's important. Unfortunately, we aren't allowed to keep them in a bubble and then test one thing at a time like we would like. But this is where kind of the collaboration really comes into play, is that by having such a large set of participants, we're able to kind of tease out some of those more important factors.
Yeah.
I would just say that projects like Teddy, there are several consortium projects that have been funded through projects like the Special Diabetes Program through the NIDK, and it's like without that, it's like projects like this aren't possible, because it's extremely expensive and time consuming to really do this and to get good quality data for this long.
Yes, I mean, reading about this study, maybe you can talk about some of the challenges and what you might have been looking for when you saw these patients and collected information on them every 3 months, from blood to urine to stool, nail clippings, even hair. But I heard that some of your participants didn't like getting their hair cut before the usual time. You've collected tremendous data, and what kind of things were you looking for? And that's a tremendous, I would say, effort on the side of your volunteers that volunteered them or their kids to be in the study. I don't know how you did it. And maintain such a high level of recruitment and retention in the study.
Well, I think there are a variety of reasons why it was successful. But as far as kind of what we're looking at, in some ways it was like really broad strokes of what can we possibly find. Obviously, there were some things that we were interested in looking at. Some previous studies had hinted at things, for example, cow's milk being a risk factor. And so that was one of the things that we wanted to look at as well. Nice thing about Teddy is that because it's large enough, we have the power to not just look at things that may trigger disease, but things that may be protective.
Yes.
And cow's milk was one of those that was really kind of nice, because what we found was it wasn't so much that cow's milk was a risk factor, but that, breast milk was protective. And so, understanding those kind of individual things. How do we keep these people for so long? I have to say that really goes down to the clinicians. I think that people join research because they, one, see some potential that this may help their child, as well as potential that this may help future generations. But honestly, I don't think that gets you to commit for 15 years.
Yes.
And I think the big difference there is the clinicians that we have, the team of people, and so many. I'm constantly amazed at how many people are still on this project that were on this project when I first started. And forming those relationships with the families is really what keeps the families in. One of the things we do at the end of the study is we ask them, is like, what are things you'd be willing to do again? And what are things that you think worked well or didn't work well? And consistently people praise their clinician. And it's like, it's that connection that really keeps them coming back.
That's where it's at. It's the relationship. And, you got to have faith in who you're working with. You got to have trust, and the clinicians have to have empathy and understanding. So I've done clinical research my whole career, and that's it right there for recruitment and retention, for sure. Well, let's go down some of the things maybe that you guys have discovered. How about let's just start off with viruses. Everyone has heard of the Coxsackie B virus, and I know that certain viruses have been associated with folks coming down with type 1. And the other thing I'll say is, many of my patients, they're always trying to figure out why they got type 1. And they'll say, yeah, I had this severe virus a few months before. And I used to say to myself, oh, they're full of it. They're just trying to associate something, but they might have something there based on some of your research.
I would say yes and no. How's that? So one of the things that we've learned is really the autoimmunity, the process of, the attack on the pancreas starts, often years and years before the clinical onset of diabetes.
Right.
And, and I hear those stories too from our participants where it's like, oh, I got really, really sick. And then, a month later I was diagnosed. Like, yeah, that's probably what put you over the edge. But, your body was already destroying those cells, and that had been going on for a while. Viruses have long been looked at. Some research studies have shown, okay, look, viruses definitely, and others have gone back to test it and not really been able to see any correlation. In Teddy, we were able, because we were following these children so closely, the first 4 years of life, every 3 months, we were really able to kind of look at the viruses that they were exposed to. I should also say, in addition to seeing them every 3 months in clinic, they also mailed in monthly stool samples. So we had lots of biological material to work with. And since viruses are shed in the stool, we were able to kind of analyze that. And I think one of the things that Teddy has found that is unique is that it's really how long that infection persists. So it's not that you get a virus, but it's how long does that stay? And so we saw that, you have a viral exposure and, we see it in one stool sample, then, there may be a slightly increased risk, but it's significantly different when we see it at 60 and 90 days. There's a definite increase in the autoimmunity. And so it's how long does that viral infection persist?
Yeah. And I read that, the hypothesis could be that they mutate if they've been around for a long time, and that mutation somehow leads to the development of destruction of the beta cells.
Well, viruses are amazing at being able to adapt, right? And they will live inside our cells as long as they can, and just kind of hide there. And unfortunately, the beta cells are one place that certain types of viruses are attracted to.
Yeah, and I love that quote. Studying viruses like stalking ghosts. Was that the right phrase? I love that, because then you can really, have a picture view of what it's like. It's not easy. And anybody that's knows anything about viruses, how they mutate right before you try to exterminate them, like the COVID virus, for example, all the different
absolutely
variants. So sometimes these viruses are harmless, and some others lead to the development of type 1 diabetes. What about the HLA region of the chromosome? And you might want to, if you can, explain that in more lay terms, because it's a complicated area.
So the HLA region is basically just a section of your chromosome that encodes for how your immune system responds. And so you can we talk about the antigen, say the virus, or a portion of the virus being presented to the immune system. And so the HLA region is one of the areas that decides kind of how your body responds to those. Unfortunately, certain HLA types also increase your risk for developing autoimmune diseases like type 1 or celiac disease. And so with Teddy, we started out with, I will say, because it was such an ambitious project, we really started with like the highest of the high risk. And so it wasn't designed to really catch everyone, but to catch those who were more likely to progress during the time that we follow them. And what we found, even that, there are much more that we should be looking at besides just the HLA area. And so that kind of, I'll give a quick plug for Cascade. That kind of
Yeah.
built on Cascade there, which is our next project, which we started a few years ago. And understanding, okay, these genes, each of these genes weigh a little bit differently, as well as some of them provide protection against others. And so understanding where those are and how that interplay goes, to allow us to better, in the future, give a risk estimate, to the parents of their children, of like, over their lifetime, what are their chances of developing type 1 diabetes.
Yes, and as I understand it, Cascade is looking for more interventions to prevent the development of type 1. I mean, I've heard you say, finding the cause is one thing, but then finding an intervention is another. And is that what Cascade is about?
Well, kind of. Cascade. Our goal is really to get screening to be part of the standard of care. Studies like Teddy have really shown us a lot, but Teddy, where it's like, we did this very expensive typing, we also did a very expensive follow-up. It's not practical. We just, quite frankly, we don't have that many healthcare dollars to spend on it, unfortunately. And so Cascade, we were able to take some of the things that we learned, and it's like, okay, what is really important here when it comes to predicting and understanding a child's risk? And so we better defined, the genes that we look at, as well as kind of what the antibody schedule is. When you have a very robust antibody schedule like Teddy had, we're able to then pull out certain visits and be like, okay, at what point do you start losing, actual cases? And so then narrow it down to really just about 3 visits that they need to do over childhood, which is, incredible to think, we were doing more than that in their first year. So,
well, that's what you discovered. The high risk times to do studies and look for these markers. Now, I've heard you talk about modulators, and so can you talk about like vitamin D, vitamin C, omega fatty acids, and what kind of results have you gotten in terms of their role in delaying the progression to type 1 in high risk individuals?
So I should start off. I'm not the nutritionist, so maybe not the not the perfect person. But these things help. Vitamin D particularly will help kind of lower your immune response. And so when you have someone with a very with autoimmunity, potentially vitamin D can kind of decrease that response. And what we found is that there's, just like anything, there are huge variations in that. One of the things that we discovered was it had been shown before there's a vitamin D receptor gene, but one of the things that we found was that certain types of that gene, even if doesn't matter how much vitamin D supplement you get, your body can only absorb so much.
Mm-hmm.
And so, the idea that we would just be able to give everyone vitamin D supplements it's not as effective, as well as potentially the amount that you'd have to give could be a little toxic. But understanding kind of how these things play, and as well as in the different individuals and the gene and the environmental interaction there, understanding that a little bit better kind of helps us understand and develop better interventions. I think there is, I can't remember where it is right now, but I think there are a couple of studies that are looking at vitamin D interventions, mm-hmm. To kind of slow down or stop the immune response. And, at the point where the kids are just, I say just, but where they're antibody positive, but they have no clinical signs of type 1, which in my opinion is the optimum time. That's when we want to intervene, when you still have plenty of beta cells to make enough insulin.
I tend to agree with you. My CGM just beeped. I'm not even sure where my phone is right now, but that's okay.
In the chair next to you.
In the chair next to me. Thank you. I don't want it to beep again, but having diabetes for 54 frickin' years. Hurry up, man. I need something for people who already have it. Yeah, I was going to say that there are so many hypotheses out there. And, finding one where you can get a positive result in people who early in stage, and you're talking about stage 1 type 1 diabetes. And I happen to agree with you because the earlier you intervene, the more viable beta cells you will have. So I think, as you know now, the teplizumab story, it's proved by the FDA, TZILD, that's in stage 2, and they already have to have abnormal glucoses. So I think, our philosophy is the same, and probably most people. The earlier you can intervene, the better, but trying to identify those individuals. Now, you said that you took the very high-risk patients and then looked at some of these potential causative factors. What was your definition of a high-risk individual that would be put into TEDdy?
So so there is I'm trying to think what our absolute criteria was. So the idea was if you look at risk over time, the top 10% of the people who would develop type 1 diabetes. So basically, they had to have to be in the study. They had to have all both copies of genes that put them at risk. We kind of define the genes as, susceptible, resistant, and neutral. And susceptible and neutral is still at risk for diabetes, but it's not as high a risk. And so all of these children had to have, really both susceptible genes, and a subset of our population obviously also had, family members with type 1 diabetes. And so they had, additional genes that were going on behind the scenes that we weren't necessarily looking at initially for screening.
Yeah, we know having a first degree relative puts their risk 15 times higher than others, and so that's important. And then they really get into it. If you have 2 relatives that have type 1, if you have your mother who has type 1, your father, or identical twin, so you took these high risk individuals and look for triggers that either prevented them or protected them from going on to type 1. Well, if you had to summarize I know this is off the top of your head, some of the key findings of the TEDdy so far, and how many individuals were in the TEDdy study? I believe it was 6,000. Is that right?
Actually, a little over 8,700, almost 8,800.
Wow. Yeah. How could you summarize what some of your findings to this point in time?
Well, I think, kind of going back to what we were saying before, one of the things that we've really found is that this autoimmunity starts really, really young. Not just for type 1 diabetes, but also for celiac disease and also for autoimmune thyroid disease, which we were studying those diseases as well because there's a link between them and type 1, and we wanted to understand that link. Mm-hmm. I was amazed, typically you look at thyroid disease and you don't expect to see anything until, right around puberty, whereas we were seeing things significantly much earlier than that. I think that's exciting. I think that provides, potentially another opportunity of a way to intervene, a longer time to intervene. Other things that we looked at are kind of discovered is that there are different types of type 1, if you will. The outcome is the same, but kind of the way you get there is very different. The younger you are, the more aggressive the autoimmune process is. And, we saw kids who would be, they would go from antibody negative to antibody positive and then type 1 in a course of like 3 months. Mm-hmm. Whereas with the teenagers, you don't see that. It takes years. And then as you get, older, adults develop type 1 as well. Just as many adults develop type 1 as children do, which is why we've gotten away from calling it juvenile diabetes. But, the disease process in adults tends to be a bit slower as well. And there are a variety of factors why that may be the case, but these do tend to show up, and the way that you would want to treat them and address them are different. There are other things that I thought were, we talk about viruses. Viruses to me is pretty exciting because we know how to deal with viruses. We have a very low toxic way of dealing with viruses. Vaccines work. And if you're able to screen all of the children and understand, know the children who are at risk, then, potentially you could change their recommended vaccine schedule and, quickly reduce the incidence. We may not get rid of type 1 altogether, but quickly reduce the incidence without introducing a lot of, typically it's the immunomodulators that you'd have to use, whereas this is a much lower toxic and, something they won't have to be on for the rest of their life, if you will. Another finding that we found that I think I say this every show I'm on, so forgive me.
That's okay.
But probiotics in the first month of life, we were not expecting this. The nice thing about being in 4 different countries is that there are different recommendations for introduction of foods and medications and probiotics in the first month of life. Actually, we saw a difference in autoimmunity. These children had a lower incidence of autoimmunity than those that didn't. And I love probiotics. It's like no toxicity. And it's just generally good for you anyway.
Are the probiotics in the milk? Or how do you give the kid that can't chew, obviously, no teeth?
Right. So they have a liquid formula that they would put in the bottle. And so you can mix it either with breast milk or with the regular cow's milk formula.
Wow. Well, the other issue that you touched on is celiac and autoimmune thyroid disease, and that's Graves' and Hashimoto's. Yes, as I understand it, those folks have a much higher risk of developing type 1 diabetes, after developing one of those autoimmune conditions. And would you put them on the same level of risk as a first-degree relative with type 1? And those individuals, my impression is they should be at the highest level of screening along with family members.
I don't know that we necessarily put them on the same risk level. Celiac disease, it does increase your risk. The problem is that with to take celiac disease for example, it's like you could be at risk for celiac, but then have one copy of the gene that's protective against type 1. It's not going to protect you against celiac disease, but it would be more protective against type 1. And so their risk may not be as high. But I do agree with you completely that, these people have some of the genes that would increase their risk. And so it is absolutely worth screening them and worth looking at. We know, and we've seen over and over, not just in Teddy, but in other studies, that, the earlier you catch it, the better the outcomes. And those outcomes, those improved outcomes last for years after diagnosis. And so it's not just avoiding hospital stays and time in the ICU. It's better glucose control for years to come.
Yeah, and I'm glad you mentioned that, because one of the benefits of screening in a study like Teddy or any study for type 1 in the early stages is that everyone gets educated on the signs and symptoms of when diabetes starts to kick in, and you could avoid, like you said, intensive care unit visit, a really dramatic presentation where the whole family's disrupted. So I think even knowing that you have risk is important, and that has long-term benefits because you can have better control from the very beginning. Well, Michael, in 2025, where do we stand with screening for type 1? And if your centers are still looking for individuals for future studies, it's probably good to let us know how to get more information.
So I will say in 2025, it is very exciting for screening. And part of that really is with the first approval of an FDA drug prior to diagnosis. I think that's going to be one of many that are that come out. But, it's very exciting. There are programs all over the world that are coming up. We actually collaborate with quite a few of them, providing genetic and antibody work for them. So it's an exciting time, but at the same time, there's still so much to do because so many providers don't know who should be tested, and don't necessarily have the information. And so that's still very much a part that we and others are working on, is because it's like you don't necessarily expect the general population to know, but certainly when they're seeing their provider, they should be able to make those recommendations, and those are changing. Cascade right now is just screening newborns up to 9 months born in Washington State. And the reason why we're using that group is that this project will end with an application to the Board of Health to add type 1 screening to the newborn panel. And so we're working with the newborn screening program so that we are using the exact same samples that they collect. We're not collecting anything more, but to demonstrate that those samples work and it's sufficient, and it can be done without by their current system.
And that, just to reiterate, that's all babies, not babies with a family history or any risk factors. So I think
Correct.
that'd be cost effective as well. I think we want to change someone's life for the better, but if it's cost effective, it's a win-win.
Well, and unfortunately, I mean, it really does have to be cost effective, because I mentioned earlier, it's like we only have so many healthcare dollars, and and trying to look at how that gets spent effectively. And we have an economist that's working with us that it will help us with this final application to look at okay, if we look at screening everyone, and then the children that need to have antibody follow-up, what does that look like compared to we don't do anything, and then the children in the hospital and the ICU stay. And it's been, for a long time, it's been like, okay, the math doesn't add up. It costs way more to screen. But I think that we are, if not there, we are really, really close.
Yeah. Well, thank you for that. Well, in closing, I want to make sure all of our viewers and listeners know that any first-degree relative of someone with type 1 and or with other autoimmune conditions really should be screened. And it's very easy to get screened these days. Information for screening is on our website at tcoid.org. And if you want more information about Michael and all the studies they're doing, specifically the Teddy and Cascade, I would say pnri.org. Would that be the best website?
Absolutely. And, we have in the past kind of done, we don't necessarily have a general population project right now, but it is something that we're hoping to get kind of up and going again. And so, our website would be a great place to kind of get that information as those things evolve.
Well, thank you so much, Michael. It's been an ultimate pleasure of mine to get to talk to you about this, such an important study that's been going on for so long on a very complicated condition, such as the cause of type 1 diabetes.
Thank you so much for your time.